Hello everyone, welcome to my YouTube channel, a dedicated platform for mastering clinical medicine. This channel provides in-depth, structured teaching on history taking, general physical examination, and all the systemic examinations, tailored for medical students, doctors, and healthcare professionals. The focus is on building strong clinical foundations, improving diagnostic skills, and developing a clear practical approach to patient evaluation. Join me as we simplify complex concepts and strengthen clinical excellence through detailed, exam-oriented, and practice-focused learning. With that said, let's jump to today's topic.
The PDF of the lecture notes is available on Gumroad. You can download it and follow along with the video lecture for a better and more effective learning experience.
Part 3 of the course Foundations of Clinical Assessment, in which we will learn about history taking, general and systemic examination. In this part, we learn about CNS examination. First, we get ready for CNS examination. Then we follow a logical sequence in our examinations. First, higher mental function examination. Underneath, we will learn about the appearance and behavior of the patient, delusion, hallucination, and illusion. And then we calculate Montreal Cognitive Assessment score, and then some of the primitive or released reflexes. Then we jump to speech examination. Underneath, we will learn about Broca's and Wernicke's area, their function, location, and then dysfunction. And then we will differentiate among dysphoria, dysarthria, dysprosody, dysphasia, or aphasia, and then performing speech examination on a patient. Then we focus on 12 cranial nerves with signs and symptoms of dysfunction, starting with olfactory nerve, optic nerve, and then we study 3 cranial nerves together, such as oculomotor, trochlear, and abducent nerve. Then we discuss trigeminal nerve, facial nerve, vestibulocochlear nerve, glossopharyngeal nerve, vagus nerve, accessory nerve, and then the 12th one, which is hypoglossal nerve. When we are done with the cranial nerves examination, then we proceed to motor system examination, in which we measure bulk of muscle, tone of muscle, power of muscle, superficial and deep reflexes, and then we look at the gait of the patient and some involuntary movements, and then we look at the cerebellar dysfunction, which appear as cerebellar signs. Then we perform the examination of sensory system. Underneath, we will try to examine primary and cortical sensations, and then there are some other miscellaneous tests like signs of meningeal irritation in a patient having meningitis, or signs of root irritation in patient having sciatica, auscultating neck and head to find out bruit due to stenosis of common carotid arteries, and then examination of autonomic nervous system. How to get ready for CNS, central nervous system examination? Prepare your tools, like prepare your pen, stethoscope, pen light, tongue depressor, reflex hammer, otoscope, ophthalmoscope, and as well as tuning fork to rule out hearing impairment in the patient. Maintain patient privacy, asking other people to leave the room, and if the patient is female, ask a chaperone to accompany you throughout the examination. Approach the patient from right side, introduce yourself and explain the procedure, and then take informed consent. Informed consent means that you have explained the procedure completely and the patient exactly knows what you are performing and why you are performing it, and then he has shown his acknowledgement or agreement to proceed to examination. Now, why it is important or significant to perform central nervous system examination? First thing you should remember, fear of CNS examination is very common among doctors and medical students because evaluation of neurological problem is mathematical and follows a logical sequence and needs knowledge of neuroanatomy and neurophysiology. So CNS examination provides essential information about functional status of the brain and spinal cord, cord and peripheral nerves, which guides your diagnosis and management, and it narrows down your differential diagnosis or provisional diagnosis. So we need to follow a logical sequence during our CNS examination, which is consisting of 7 parts. Number 1 is higher mental function examination, then speech examination, then cranial nerves examination, then motor and sensory systems examination, then examination of cerebellum function, and then there will be some miscellaneous tests like looking for signs of meningeal irritation, signs of root irritation, auscultation of neck and cranium, and then looking for signs of tetany, and then examination of autonomic nervous system. So let's first jump to higher mental function examination. In higher mental function examination, the first thing that you have to do is look at the appearance and behavior of the patient. Either patient is alert and cooperative, either he is restless or agitated, patient's look is groomed or unkempt, or does the patient take interest in the surrounding or not. Then try to find out disorder of thoughts, which can be delusion, hallucination, or illusion. Now let's first know what are the differences among them and what are their definitions. Delusion means false belief that cannot be corrected by argument or logics. Hallucination means perception of stimulus which even does not exist. For example, the patient says somebody is touching me, however there is nobody to touch him. And illusion means misinterpretation of stimulus, like a shadow of a person appears like a monster or devil to him. So this is how he misinterprets normal stimulus. Then third thing that you have to do in higher mental function examination is Montreal cognitive assessment, which is a modified form of mini mental status examination. You should remember the mnemonic LORA. L stands for language, O stands for orientation, R stands for registration, and next R stands for recall, and A stands for attention. The first parameter in the Montreal cognitive assessment is language, and the total score is 9. Present an object, ask the patient to name it, and at least present 2 objects and give 1 score for every correct name. Second thing that you have to do is ask the patient to repeat a phrase, and if the patient can repeat the phrase correctly, give a score 1. Then give a 3 steps command. For example, ask the patient to pick up a paper, fold it, and put it back. For every correct step, give 1 score. Fourth thing in case of language examination is ask the patient to obey a command written on a paper and give 1 score if the command is performed correctly. Ask the patient to write a sentence and the sentence is correct, give 1 score. And the last thing that in this category is that ask the patient to draw an illustration like a triangle, and if he can draw the illustration, then give a score 1. So there is the illustrative explanation of the parameter language. The second parameter is orientation, and the total score is 10. Ask 5 questions about time, like what time is it, what day is today, what year is today, when is your birthday, and when was your graduation. And then ask 5 questions about places, like what is the capital city of Australia, where are you right now, where is your hometown, where is your birthplace. So give 1 score to every 1 correct answer out of 5 questions. The third one is registration, where you check the short-term memory of the patient, and the total score is 3. Ask the patient to remember 3 words, and in recall, after 5 minutes, repeat those 3 words that you ask the patient to remember them, and give 1 score to every 1 correct word. And then the last one is attention. The total score is 5. Ask the patient to spell a word containing 5 letters in backward fashion, like the word world, and ask the patient to repeat it backward, like, or spell it backward, like DLROW. So the figurative aids and supplements of each parameter of Montreal cognitive assessment is being provided to you on the side of the text. Now, before jumping to the interpretation, you should know the differences among cognition, intellect or intellectual, and intelligence. Cognition means mental processes like memory, thinking, thinking, which involves reasoning, judgment, and problem solving ability, and perception, like face recognition, interpret depth, visual clues, scent in the air, or change in the tone. And this is called cognition. Now, the outcome of these processes, the outcome of the thinking, memory, and perception is called intellect or intellectual. The outcome can be poor or can be outstanding. And the effective application of these mental processes is called intelligence. Like if a person has good memory, if a person has outstanding and remarkable ability of reasoning, judgment, and problem solving, so we call that person to be intelligent. Now, Montreal cognitive assessment, how we have to interpret the Montreal cognitive assessment. The total score is 30, as we already know it. If the score is between 24 to 30, normal cognitive function of the patient. But if the score is between 21 to 24, there is mild cognitive impairment. And if the score is between 10 to 20, there is moderate cognitive impairment. And if the score is below 10, then there is severe cognitive impairment. Where do we use the Montreal cognitive assessment? For monitoring the cognitive decline in a patient, in patient with Alzheimer's disease, differentiating between dementia and delirium, and diagnosing pseudodementia. Pseudodementia is the cognitive impairment due to some psychological issues like depression or anxiety. So in case of higher mental function examination, we learned about this, that what does the appearance and behavior of the patient tell us. Then we try to know about the delusion, hallucination, and illusion, which are the disorder of thoughts. Then we calculated the Montreal cognitive assessment score. Now it is time for us to check the long-term memory, like ask about any past event, and then check the intelligence of the patient by asking about his performance at school, at work, or in college or university. Then if the patient has presented to you unconsciously, then you need to calculate Glasgow Coma Scale. Now, Glasgow Coma Scale is having three categories: eye movement, verbal response, and motor response. In case of eye movement, the total score is 4. If the patient opens his eyes spontaneously, then give a score 4. And if the patient opens his eyes only as, then give a score 3. If the patient opens his eyes when pain stimulus is given, then give a score 2. And if the patient does not open his eyes at all, then give a score 1. Then verbal response, the total score is 5. If the patient answers your questions correctly, then give a score 5. And if the patient is confused about something or about the question that you're asking, like what day is today, like then he says Tuesday, no, today is Friday, maybe, right? Then give a score 4. If the patient gives inappropriate answer, like you ask him how are you and he says get off me word, then give a score 3. And if the patient answers with incomprehensible voices or sounds, then give a score 2. And if the patient does not respond at all, then give a score 1. Now, verbal response in case of infant or children is kind of different. You have to give a score 5 to an infant which coos and bubbles, and give a score 4 to an infant who has irritable cry but consolable, and give a score 3 to an infant who has persistent and irritable cry which is inconsolable, and give a score 2 if the child is restless, agitated, and grunting, and give a score 1 where there is no response at all. The last category of the Glasgow Coma Scale is motor response, and the total score is 6. If the patient obeys command, give a score 6, like ask him to touch his ear. If the patient localizes the pain, then give a score 5. If the patient withdraws from the pain, then give a score 4. If the patient does the flexion of the upper limbs and extension of lower limbs in response to pain stimulus, then give a score 3. And if there are extensions of upper and lower extremities in response to pain stimulus, then give a score 2. And if there is no response to pain, then give a score 1. So the total score of the Glasgow Coma scale is 15, and the least score can be is 3. So how do you interpret the GCS or Glasgow Coma scale? If the GCS is between 13 to 15, then there is mild head injury. And if the GCS is between 9 and 12, then moderate head injury. And if the GCS is between 3 to 8, then there is severe head injury. Then you have to check some release reflexes. Release reflexes are reappearance of primitive reflexes which indicate brain damage, like grasp reflex, which indicate contralateral frontal lobe injury, or avoiding reflex, which may show contralateral parietal lobe injury. And how do you perform the avoiding reflex? Stroke the ulnar side of palm and patient moves hands away. Palmo-mental reflex, how do you perform it? Scratch over the thenar eminence, side of thumb. The patient pucker his chin. And snout reflex, it occurs when there is bilateral upper motor neuron lesion. Apply pressure on lips with knuckles or fingers, then patient puckers or protrudes his lips. And glabellar tap reflex, normally when glabella is tapped repeatedly, then 2 to 3 times, blinking occurs and then stops. But in Parkinsonism and senile dementia, blinking does not occur, and this is called glabellar tap reflex. So some illustration of the release reflexes are being added to the text. So after examination of higher mental function, now it is time for speech examination of the patient. Before initiating the speech examination, there are some basic terms and knowledge that every doctor or medical student should know. First, what is language? Language is communication of thoughts and ideas through signs, voice, and symbols. For example, by writing, by speaking, or with the body signs or gestures. And why language is important? Because speech is considered to be oxygen of mind, without which you suffocate. So every human being on earth needs to communicate with the next person so that to relieve his emotions, so that he has to make himself empty with the pain, with any other emotional burden that he or she is bearing. So whenever we want to study speech, two areas in the brain are very important to be studied. One is Wernicke's area and other one is Broca's area. Now Wernicke's area, the visual image through eyes, auditory information through ears, and touch sensation through peripheral sensory system comes to the Wernicke's area, and the Wernicke's area converts it into mental sound or idea. So basically Wernicke's area is your mental dictionary, and it is a comprehension area where it tries to understand the visual, auditory, and sensory informations which are being brought by the other sensory or by other systems of the body to the Wernicke's area. Now if the Wernicke's area is damaged, then it leads to aphasia or dysphasia. Aphasia means complete loss of language, while dysphasia means partial loss of language. Now there will be failure of comprehension of visual, auditory, and sensory information. In other words, you see, you can hear, and you can feel, but you cannot get a sense out of them. So the other important area in the brain which is involved in speech production is Broca's area. So when the Wernicke's area convert the visual, auditory, and sensory information into a mental sound or idea, then Wernicke's area send this mental sound to Broca's area, and Broca's area codes these into motor activity to produce sound. So if Broca's area is damaged, so then there will be failure of speech output. I mean, patient can see, hear, and feel and understand them as well, but cannot bring it into motor activity. So Broca's area codes the motor activity, and this motor activity is bring out by organophonation and organ of articulation. Organophonation is vocal cords which produce simple voice, like we have vowels in our in English alphabets like a, e, u, u, I. And organ of articulation like lips, tongue, soft palate, which modify simplify the simple sound into meaningful words. Now, you have to remember some specific cranial nerves which are supplied to organ of articulation, and these nerves need to be intact so that the organ of articulation can perform its function properly. Like lips are supplied by 7th cranial nerve, soft palate is supplied by 11th cranial nerve, and tongue is supplied by 12th cranial nerve. Now, if the organ of phonation is damaged or there is damage to the nerves of the organ of phonation, then this is called dysphonia, means sound production is impaired. In other words, change in quality of voice. And if the organ of articulation is injured or the nerve supply to the organ of articulation is not intact, then this leads to dysarthria, means sound modification is impaired. So we talked about the Broca's area and Wernicke's area. Where are they situated in the brain? Now, Broca's area is located at inferior frontal gyrus of dominant hemisphere. Once again, I'm telling you that it is present in the inferior frontal gyrus of dominant hemisphere, and Wernicke's area is located at the superior temporal gyrus of dominant hemisphere. You need to ask yourself that if Broca's area and Wernicke's area are located in dominant hemisphere, then what are the functions of corresponding areas in non-dominant hemisphere? So now let's learn about the pathway of a meaningful sound production. Wernicke's area makes mental sound or idea by understanding the visual, auditory, and sensory input. Then this mental sound or idea is sent to Broca's area by arcuate fasciculus, which are bundles of nerves. Then Broca's area along basal ganglion code motor activity for producing sound, and this code is being sent to primary motor cortex, which activates the upper motor neurons such as corticobulbar tract, and then it's being sent to lower motor neurons like trigeminal nerve, facial nerve, glossopharyngeal nerve, vagus nerve, and hypoglossal nerve. And each of these cranial nerves control the organ of phonation or organ of articulation. So damage in any part of this pathway will lead to speech abnormality. So there is an illustrative image, like visual information is coming into the Wernicke's area. Wernicke's area makes the mental sound and send it to Broca's area through arcuate fasciculus, and then Broca's area codes motor activity, which it sends it to primary motor cortex, and then primary motor cortex activates the upper motor neurons and lower motor neurons, and then patient will be able to say that it is an apple, means he understands the visual information and he puts it into words. So let's discuss about etiology of dysphonia, means the sound production is impaired. Why? Because organ of phonation, which are vocal cords, are not functioning properly. So dysphonia can be caused by psychogenic causes like conversion disorder, anxiety, depression, somatization disorder, factitious disorder, and malingering even. So how can you differentiate between organic cause and non-organic cause? Ask the patient to cough. If the patient can cough but cannot speak, so it has a non-organic cause, means the etiology of the dysphonia is psychogenic. Now there can be some extractional causes of dysphonia like inflammation such as laryngitis or GERD, rhynchiedema, vocal nodules, vocal cyst, vocal papilloma, which is caused by human papilloma virus, and they change the quality of voice, and malignancy of larynx, or hypothyroidism where there is deposition of the glycose aminoglycans like hyaluronic acid, and acromegaly when there is high level of growth hormone. Dysphonia can also be caused by some neurogenic causes like recurrent laryngeal nerve is damaged during thyroidectomy, vagus nerve lesion, upper motor neuron lesion, basal ganglion lesion occurs in Parkinson disease, or myasthenia gravis and Lambert-Eaton myasthenic syndrome where there is problem in neuromuscular junction, or there can be amyotrophic lateral sclerosis. We will discuss about them in our CNS module in details. Or dysphonia can be caused by spasm, like it's called spasmodic dysphonia. If if there is a spasm of adductor muscle, then patient will have strained voice, and if there is a spasm of abductor muscles, then patient will have breathy voice because the vocal cords are open, completely open, and in case of adductor, the vocal cords are completely closed. So now what are the etiology of dysarthria? Means sound modification is impaired due to damage in organ of articulation like lips, tongue, soft palate. So dysarthria is caused by corticonuclear lesion, cerebellar lesion, corticobulbar lesion, neuromuscular junction lesion like myasthenia gravis, and Lambert-Eaton myasthenic syndrome, and amyotrophic lateral sclerosis, and we will discuss about them in details in our CNS module. So dysphonia can also be caused by spasm of the adductor or abductor muscles of vocal cords. Like if there is a spasm of adductor muscle, then the patient will have strained voice because the vocal cords are completely closed. And if there is a spasm of abductor muscle, then vocal cords are completely open and patient will have breathy voice. Now let's discuss about the etiology of dysarthria. Means there is impairment of sound modification due to injury to organ of articulation or injury to the nerves which are being supplied to organ of articulation like lips, tongue, soft palate. So the causes of dysarthria can be corticonuclear lesion, cerebellar lesion, corticobulbar lesion, neuromuscular junction lesion like myasthenia gravis and Lambert-Eaton myasthenic syndrome, or myopathies. Now this is time for us to discuss about dysprosody. Before talking about the causes or etiology of dysprosody, let's first know what it is. So do you remember the location of Broca's area and Wernicke's area? We know that Broca's area is located at the inferior frontal gyrus of dominant hemisphere, and Wernicke's area is located at the superior temporal gyrus of dominant hemisphere. Then I ask you, what are the functions of the corresponding areas in the non-dominant hemisphere? So corresponding areas in the non-dominant hemisphere are involved in detecting emotionality in speech or expressing emotionality in speech. So dysprosody means that the corresponding areas in non-dominant hemispheres are being damaged. So if there is a lesion in area corresponding to Wernicke's area of non-dominant hemisphere, then it is called receptive dysprosody. Means patient cannot detect emotionality in speech, like he cannot understand the joke or sarcasm. And if there is lesion in area corresponding to Broca's area on non-dominant hemisphere, then it leads to expressive dysprosody. Means the patient has a monotonous speech because of no change in pitch, no intonation, and no gesture when speaking. Means emotionless speech. So let's now discuss about the etiology of aphasia or dysphasia. Since we know that aphasia means complete loss of language, while dysphasia means partial loss of language, and aphasia or dysphasia can occur when there is damage in any of these three structures like Wernicke's area, Broca's area, and arcuate fasciculus. If the damage is purely confined to Broca's area, then it's called Broca's dysphasia, or if damage or lesion is confined purely to Wernicke's area, then it's called Wernicke's dysphasia. Conductive dysphasia occurs when there is damage to arcuate fasciculus and patient is unable to repeat words. Transcortical sensory dysphasia occurs when the contact of Wernicke's area with its surrounding is lost, and transcortical mixed dysphasia occurs when the contact of both Wernicke's area and Broca's area are lost with their surroundings. Nominal dysphasia occurs when patient is unable to recall names of the objects, person, and place. Why? Because there is damage to posterior part of Wernicke's area. Because posterior part of Wernicke's area is concerned with the names of objects, persons, and places. Global dysphasia occurs when all the three parts are damaged, like Wernicke's area, arcuate fasciculus, and Broca's area. Anterior basal nucleus dysphasia occurs when there is Broca's aphasia dysphasia combined with contralateral hemiparesis, and posterior basal nucleus dysphasia occurs when there is Wernicke's aphasia along with contralateral hemianopia. Thalamic dysphasia occurs when there is damage to ventroanterior and ventrolateral nuclei of thalamus, and watershed infarct-related dysphasia when there is occlusion of middle cerebral artery. So the image is also being provided for an easy and quick recall of the causes of aphasia or dysphasia along with the lesions. Well, since you're a doctor, you should know how to perform the speech examination professionally so that it would help you in your diagnosis or narrow down your differential diagnosis. If anybody has presented to you with speech difficulty, the first thing that you have to do is assess the spontaneous speech. When the patient is talking, ask yourself the following question: is speech fluent or non-fluent? Is it meaningful? Is the grammar intact? Is speech effortful or not? So how do you interpret it? If the speech is non-fluent but effortful, then you may think of Broca's dysphasia or dysarthria. But if the speech is fluent but meaningless, then you can think of Wernicke's dysphasia. Now, next thing that you have to do is test comprehension. Ask the patient to show two fingers if the patient follows the command. So the speech difficulty can be because of Broca's dysphasia or dysarthria. But if patient cannot follow the command, then it can be because of Wernicke's dysphasia. Then test the repetition. Ask the patient to repeat a phrase or sentence like "the sky is blue." If there is impaired repetition but the speech is fluent, then it points towards Wernicke's dysphasia. If the patient has impaired repetition and as well as speech is non-fluent, then it can indicate towards Broca's dysphasia. Fourth thing that you have to do is naming test. Show few objects to the patient like watch or pen. Now ask the patient to name these objects. If the patient names the objects correctly but with difficulty, then speech problem can be because of Broca's dysphasia or dysarthria. But if the patient names the object incorrectly, then it can indicate Wernicke's dysphasia. Fifth thing that you have to do is reading and writing test. Ask the patient to read a sentence aloud and write a simple sentence. If reading and writing are not impaired, then your differential diagnosis can be dysarthria. But if the reading and writing are impaired, this can point towards Broca's dysphasia and Wernicke's dysphasia. Then differentiate between dysarthria and dysphasia. Ask the patient to repeat pa pa pa. Here you need to check the organ of phonation, lips, ta ta ta. Check the function of tongue, ka ka ka. Check the function of throat or guttural. If the patient has slurred speech but language is intact, your final diagnosis is dysarthria. But if the patient has fluent language but meaningless, then it can be dysphasia. Now check the coordination of organ of articulation. Ask the patient to repeat pa ta ka. If patient has slurred speech but the language is intact, so it can be caused by dysarthria. Now you need to assess voice quality, means rule out dysphonia. Ask the patient to produce a sustained voice like any of the vowels. Like ask the person to say e, and you start counting and check either there is change in the quality of tone or not. Well, this is how you perform speech examination to narrow down your differential diagnosis. Now let's jump to cranial nerves examination. Since we know there are 12 cranial nerves and we need to test every single of them, either they are functioning properly or not. Starting with the first cranial nerve, which is olfactory nerve. We start the examination of the olfactory nerve by asking the patient either he can appreciate smell or not, and then we exclude local nasal pathology by testing patency of the nostrils separately, and this is also called cocaine pot test. And then we prepare some items as you see in the image, and we ask the patient to close his both eyes and one of his nostrils and snuff the items and identify the smell. So, and trauma to olfactory nerve leads leads to anosmia. That is, that the patient is not able to appreciate scent or smell, and this may be caused by head injury, tumor of anterior cranial fossa, or tuberculous meningitis. Or if there is non-organic cause, then this may lead to parosmia, means a pleasant smell is perceived as offensive, and this occurs in psychogenic causes. And there can even be hallucination of smell. Hallucination means to perceive a stimulus which even does not exist, and this occurs in temporal lobe epilepsy or seizure. As you see in the image, first thing that you have to ask from patient is either he can appreciate smell or not, then check the patency of each nostril separately, and then ask the patient to snuff the items and identify the smell. The second cranial nerve is optic nerve, and in this domain we will cover following aspects like visual acuity, color vision, field of vision, and then fundoscopy. Under the heading of visual acuity, we have to assess near vision with the help of Jaggers chart. We put the Jaggers chart 10 inches away from the patient and ask him to read it loud. As you see, the Jaggers chart is having different paras of the text, and we will see how much of it can be read by the patient. For far vision, we use Snellen's chart, as you see in the image of the Snellen's chart. For instance, if the far vision of the patient is 20 by 40, what does it mean? It means that the patient reads at the distance of 20 feet, which he was supposed to read at distance of 40 feet. When we find out that the far vision of the patient is 20 by 40, then we refer the patient to optometrist for obtaining precise lens power, and the lens power is obtained using refraction test by the optometrist. For color vision, we use Ishihara chart. As you see, there is a hidden letter or hidden number inside it, and we ask the patient to read it. If the patient can read or identify the letter or digits inside it, then he does not have any color vision. Then field of vision, the charting of field of vision or measuring the boundaries of the field of vision can be done by confrontation method or perimetry. In confrontation method, the doctor and examiner are at the distance of 1 meter, and both are looking towards each other's eyes, and the examiner stretch his arm, then bend it in such a way that his fingers are midway between him and the patient, and then he asks the patient to fix his eyes while other eye is covered and say yes when he sees any movement or flickering of the fingers of the examiner. Perimetry is more accurate way of measuring the boundaries of field of vision or charting the field of vision. And there are two types of perimetry. One is called static perimetry, which includes Humphrey and octopus, and the other way is kinetic perimetry, which includes tangent screen and Goldman. And however, confrontation method is a type of kinetic perimetry, but it is less accurate. Now, why we need to measure the boundaries of the field of vision or chart the field of vision? The reason is to diagnose scotoma. Scotoma is a pathological blind spot, and this pathological blind spot is found due to defect anywhere along the visual pathway from retina to the occipital cortex. But before jumping into the defects which we find in the visual pathway, we should know about the physiological blind spot, and as well as we need to define the visual field. Physiological blind spot is an area on the retina where optic nerve originates, and this area is devoid of the light sensitive cells like rods and cone cells, and this area is located at 15 degree lateral to the central fixation point on the temporal side. However, this blind spot does not appear as a dark spot in our visual field. The reason is that the primary visual cortex merges it with surroundings. fields. So let's now define the visual field. When a person fixes his gaze on an object with one eye and while other eye is being covered, the external area around the object is also visible, and this external area is called visual field. And the boundaries of the visual field on the lateral or temporal side is 90 to 100 degree. Why it is so widened? The reason is that there is no obstruction. The inferior boundary is 75 degree, which is above the cheeks. The medial boundary, which is also called nasal side, it is 62 degree, and the superior boundary of the visual field is 55 degree. The reason that it is small is because it is confined by supraciliary arc. When left and right visual fields overlap, they form binocular visual field. So now let's study about the visual pathway, and when there is any trauma or injury to visual field, then which sort of abnormalities may arise. The light is converted into electrical signal, and this process is called phototransduction, and the phototransduction is done by rods and cone cells, bipolar cells, and ganglion cells. Trauma to these cells are caused by retinal detachment, macular degeneration, diabetic neuropathy, and retinal vascular occlusion. And the axons of these cells, like axons of rods and cone cells, bipolar cells, and ganglion cells, are collectively called optic nerve. And optic disc is the area where optic nerve originates. Now, the optic nerve consists of medial fibers which are coming from the medial side of the eye, but these fibers are carrying electrical signal of the lateral side of visual field. On the other hand, the lateral fibers coming from the lateral side of the eye, but these fibers are carrying the electrical signals of the medial side of the visual field. Now, the lesions or the damage to the optic disc which contains optic nerve can be caused by optic neuritis, ischemic optic neuropathy, and glaucoma. Now, disruption of optic nerve or trauma to rod cells, cone cells, or bipolar cells or ganglion cells may lead to scotoma. Now, which kind of scotoma? The retinal trauma leads to central scotoma or paracentral scotoma, peripheral scotoma, or ring scotoma, and optic nerve lesion leads to central scotoma, centrocecal scotoma, arcuate scotoma, which is also called germ scotoma, and altitudinal scotoma. So the next thing that we have to know is that the optic nerve, the medial fibers of optic nerve cross to the opposite side, and this is called optic chiasm, but the lateral fibers do not cross. Now, lesion to or trauma to the optic chiasm can be caused by pituitary adenoma from below or craniopharyngioma from above, and this leads to bitemporal hemianopia. Bi means two, temporal means outer and lateral side of visual field, hemi means half of the visual field, anopia means missing the vision. So you can understand the abnormality from its term itself. So continuation of the optic nerve after optic chiasm is called optic tract, and there are left and right optic tract. Now, each optic tract is having lateral fibers of ipsilateral eye, means same eye, and medial fibers of contralateral eye, means opposite eye. Trauma to the optic nerve leads to either congruous homonymous hemianopia or incongruous homonymous hemianopia. Congruous means symmetrical, homonymous means same side of the visual field, and hemi means half, and anopia means missing the vision. Incongruous means asymmetrical, means different in shape. Homonymous means same side of visual field, and hemi means half, anopia means missing vision, as you see in the image. Optic tract of every side ends in the lateral geniculate body, which is nucleus. Nucleus means cluster of cell bodies of neurons in the CNS, and the collection of cell bodies of neurons outside the CNS is called ganglion. So optic tracts end here, and new fibers arise which sharpen the contrast and enhances depth of perception. And disruption or trauma to lateral geniculate body leads to incongruous homonymous hemianopia anopia. If we break down these terms, incongruous means asymmetrical, homonymous means same side of visual field, hemi means half, and anopia means missing the vision. Now, the fibers which arise from lateral geniculate body spread over the cerebral hemisphere, and this is called optic radiation. The superior fibers which pass through the parietal lobe is called Baum's loop, and injury to superior fibers leads to superior quadrantic homonymous hemianopia, and the patient will be having a visual field like these. Inferior fibers of optic radiation pass through temporal lobe, and this is called Meyer's loop. Disruption of the inferior fibers leads to inferior quadrantic homonymous hemianopia. Now, occipital lobe. Occipital lobe is being divided into Brodmann area 17, 18, and 19. Now, what is Brodmann area? Brodmann areas are the regions of the cerebral hemisphere which are being divided on the basis of cell types, their arrangement, and function. So, Brodmann area 17 is called primary visual area, and Brodmann area 18 is called visual analysis area, while the Brodmann area 19 is called visual recognition area. Now, if there is occlusion of posterior cerebral artery, then this will lead to macular sparing congruous homonymous hemianopia, as you see in the image. On the other hand, if there is occlusion of middle cerebral artery, then this leads to congruous homonymous macular defect, as you see that only macular area is not visible and the rest of the visual field is alright. Here is the image which is the summary of the whole visual pathway along with their defects. The fourth thing that you have to do is fundoscopy, and fundoscopy can be done with a direct ophthalmoscopy, as you see the image, and indirect ophthalmoscopy. So during fundoscopy, you should assess and evaluate the optic disc. So first you should really know how the normal optic disc look like. When you're looking at the optic disc, you should look at the optic disc cup, which is a funnel shaped and having the retinal vessels at the center, and the cup disc ratio is 0.2 to 0.7. And the next thing that you have to see in the optic disc is a neuroretinal rim, which is an area between margin of optic disc cup and optic disc. Normally it has uniform width and it has pink or orange color, and neuroretinal rim contains axons of ganglion cells. This is how the normal optic disc look like. Now, abnormalities that you may find in optic disc are papil edema, and papil edema is caused by high intracranial pressure or malignant hypertension or high partial pressure of carbon dioxide due to type 2 respiratory failure. Type 2 respiratory failure is also called hypercapnic respiratory failure. Why? Because there is low oxygen, means there is hypoxemia, but there is high level of carbon dioxide, means there is hypercapnia. While in type 1 respiratory failure, there is low oxygen saturation and there is either normal or low carbon dioxide. So type 2 respiratory failure is caused when there is problem in exhalation of carbon dioxide, while in type 1 respiratory failure there is problem with the alveolar gaseous exchange. Papillitis, which is the inflammation of the optic disc, it is similar to papilledema, but unlike papilledema, it has abnormal visual acuity. The other abnormality that you may find in optic disc is optic atrophy, as you see in the image. So it is time now discussing three cranial nerves together, their basics, abnormalities, and specific lesions. These three cranial nerves are oculomotor nerve, which is the third cranial nerve, the fourth cranial nerve is trochlear nerve, and the sixth cranial nerve, which is abducent nerve. So we start with the oculomotor nerve, which is the third cranial nerve. This nerve is supplied to four extraocular muscles, which are medial rectus, inferior rectus, superior rectus, and inferior oblique, and it's supplied to levator palpebra superioris, which is its function is to elevate the upper eyelid, and some parasympathetic fibers of the third cranial nerve, which is supplied to ciliary muscles and sphincter pupillae. Now, when the ciliary muscle contracts, zonular fibers relax and the lens becomes thick, and then the eye focuses on near object, means accommodation reflex occurs. And when sphincter pupillae contracts, then meiosis occurs, means the constriction of the pupil occurs. So now, since we know that the sphincter pupillae is innervated by the parasympathetic fibers of oculomotor nerve, but dilated pupillae is supplied by sympathetic nervous system, and these fibers arise from the superior cervical ganglion and they travel along the carotid and ophthalmic arteries. And as well as you should know that when both eyes have coordinated movement, when both eyes move up, down, left and right together, this is called conjugate eye movement, and this coordination is maintained by medial longitudinal bundle. This medial longitudinal bundle connects third, fourth and fifth cranial nerves together. Now, if damage or trauma occurs to medial longitudinal bundle, this is called intranuclear ophthalmoplegia. So what will be the sign if the intranuclear ophthalmoplegia occurs? The site of lesion shows weak adduction, means weakness of medial rectus occurs, while the opposite eye shows nystagmus. And remember, there is a very significant sign of multiple sclerosis, that is that there will be bilateral intranuclear ophthalmoplegia. So this was a brief basics of the oculomotor nerve. Now, if the disruption of oculomotor nerve occurs, its integrity of function is disrupted too. For instance, due to unopposed action of superior oblique muscle, eye is pulled downward and outward, and due to unopposed action of lateral rectus, eye is abducted, means eye moves laterally, and due to paralysis of levator palpebra superioris, the ipsilateral side will be having ptosis, and due to paralysis of parasympathetic fibers, there will be mydriasis, means there will be dilated pupil. As you see in the image, the right eye is downward and outward because of unopposed action of superior oblique muscle, and it is abducted because of unopposed action of lateral rectus. The pupil is dilated because of paralysis of parasympathetic fibers, and eyelid is manually elevated because of paralysis of levator palpebra superioris, which leads to ptosis. Third nerve palsy is divided into three types on the basis of etiology. One is pupil involving third nerve palsy. It means that the superficial parasympathetic fibers are also damaged, and it occurs in surgery, ankle herniation, aneurysm compressing posterior communicating artery at its junction with internal carotid artery. The other type is pupil sparing third nerve palsy, where the superficial parasympathetic fibers are spared because damage is from inside, such as medical lesions that causes ischemia, which is also called microvascular cause, like hypertension and diabetes mellitus. So in case of diabetes mellitus, along with third nerve palsy, there will be painful eye movement. The third type is divisional third nerve palsy. It means that damage to oculomotor nerve occurs either in orbit or cavernous sinus. When the third nerve enters the orbit through superior orbital fissure, then it divides into superior division and inferior division. The superior division is supplied to superior rectus and levator palpebra superioris, while inferior division is supplied to medial rectus, inferior oblique, and contains parasympathetic fibers. So these were all about the oculomotor nerve, which is the third cranial nerve. Now let's discuss the trochlear nerve. Trochlear nerve is supplied to only one extraocular muscle, which is superior oblique, and you can remember it with SO4. Now the trochlear nerve exits from the dorsal surface of the brainstem and supplied to superior oblique muscle of the opposite side. Means if the trochlear nerve is damaged, then contralateral eye is affected, and normal function of superior oblique muscle is depression and intorsion of the contralateral eye. Now, so if there is trochlear nerve trauma, then it leads to vertical diplopia when the patient tries to look downward. Why? Because the superior oblique fails to pull eye downward and outward. Then inferior oblique, which remains unopposed, pulls eye upward and outward. So when the patient tries to look downward, then one image becomes higher than the the other. Why? Because eye is extended and slightly elevated due to unopposed action of inferior oblique muscle. Now there is a natural compensation. To reduce the vertical diplopia, patient tilts head towards the opposite side. Now remember, if there is bilateral paralysis, then there will be a V-shaped esotropia when patient looks downward due to unopposed action of the medial rectus, and as well as there is excyclotropia of 10 degree or more. To identify that which side superior oblique muscle is affected, we perform Belshowski head tilt sign. And how it is being interpreted: if head is tilted towards left and diplopia worsens, and when head is tilted towards right and diplopia improves, then left superior oblique muscle is paralyzed. So this was about the trochlear nerve. Now let's discuss the abducent nerve, which is the sixth cranial nerve, and you can remember it by LR6, means it is supplied to only one extraocular muscle, which is lateral rectus muscle. Now there is a peculiar feature of the abducent nerve. It has a long intracranial route. Therefore, when there is increased intracranial pressure of any etiology, it can lead to sixth cranial nerve palsy. And also noted that pontine lesion of sixth cranial nerve is always accompanied by seventh cranial nerve palsy, means facial nerve palsy. Why? Because they are in close proximity with each other. So if there is abducent nerve palsy, then eye is medially due to unopposed action of medial rectus, and the patient will have horizontal diplopia which worsens at far vision. Face is turned into field of action of paralyzed muscle as a natural compensation to reduce horizontal diplopia, as you see in the image. Now let's jump to the steps of examination of eye. We had a brief and precise basic knowledge of the three cranial nerves. Now how you have to perform the eye examination: testing the integrity of functions of trochlear nerve, oculomotor nerve, and abducent nerve. So the first thing that you have to do is measure the palpebral fissure, which is the distance between upper and lower eyelids, and normally it is between 9 to 15 millimeters. It is used to rule out ptosis. The next thing that you have to do is evaluate pupil size, shape, and regularity. And the third thing is to test accommodation reflex. Ask the patient to look at the distant object and then your finger, which is close to his nose. If there is convergence of eye and constriction of pupil, then ciliary muscle and sphincter pupillae functions are intact. In the fourth step, rule out nystagmus, which is involuntary oscillation, means to and fro motion. How you have to perform it: hold your finger at 2 feet away from the patient and move it up, down, left, and right. And when you reach at the extreme of the movement, hold your finger for some time to note oscillation. And nystagmus is, however, well noticed through closed eyes. If nystagmus is found, then note the type, direction, and severity. First thing that you should know about the nystagmus is gaze, means is it vertical, horizontal, and rotatory, and how it is being triggered, either in upward gaze, lowered gaze, left or right gaze, means lateral or medial gaze. If nystagmus is present, then try to know the type of nystagmus. And there are 5 types of nystagmus, which are pendular nystagmus, jerky nystagmus, upbeat nystagmus, downbeat nystagmus, and gaze evoked nystagmus. Pendular nystagmus is the type of nystagmus where the oscillation is equal in rate and amplitude on both sides of central point, and this occurs in multiple sclerosis or lesion of the Galen-Mallory triangle, which the function of which is to coordinate the motor pathways, and this is also called oculopalatal tremor. And this Galen-Mallory triangle is consisting of red nucleus, inferior olivary nucleus, and dentate nucleus, and pendular nystagmus can also be caused by some congenital visual sensory defects like congenital cataract, albinism, lobar congenital amaurosis, and optic nerve hypoplasia. Other type of the nystagmus is jerky nystagmus, which is quick in one direction and slow in other direction. And nystagmus is always named in the direction of V component, and it occurs because of vestibular lesions like labyrinthitis and Meniere's disease, or there is trauma to vermis or flocculus of the cerebellum. And the third type is upbeat nystagmus, and it occurs on upward gaze, and the fast component is upward. It occurs in lesions such as upper midbrain lesion, or there is trauma to pontomesencephalic junction, or damage to medial longitudinal fasciculus, or there is trauma to the ventral tegmental tract. The other type is downbeat nystagmus, and it occurs on downward gaze, and fast component is also downward. This occurs in folliculus and parafolliculus lesion of cerebellum, or there is disruption of craniocervical junctions such as chiari malformation, foramen magnum tumors, and basilar invagination. The final type of the nystagmus is gaze-evoked nystagmus. It means it's a type of nystagmus which changes its direction with direction of gaze. Now, the defect is in gaze holding, means the problem is with the neural integrators, which is controlled by folliculus and parafolliculus of cerebellum and brainstem gaze center such as pontine and midbrain integrators. So when you know about the direction, about the types, and how it is triggered, then you have to know about the severity of the nystagmus. Nystagmus is having three grades. In grade 1, nystagmus is produced only when eye is moved in the direction of fast component. In grade 2, when nystagmus is produced only when eye is in mid position. And in grade 3, nystagmus is produced even when eye is moved in the direction opposite to the fast component, means when the eye is moved in the slow component of the nystagmus. So far we completed 4 steps, means first we measured the palpebral feature, then we evaluate pupil size, shape and regularity, then we tested the accommodation reflex, and then we rule out the nystagmus. So the 5th step is to elicit light reflex. Ask the patient to look straight and focus on any distant object. Place your hand over the nose to block direct light to the other eye, and shine direct light into eye from the side. In response to light in the same eye, pupil constricts followed by slight dilation, while in the other eye there will be consensual light reflex, means the same effect is produced though no direct light is falling on it. So light reflex is having reflex arc, means it is afferent pathway is made by optic nerve and efferent pathway is made by the oculomotor nerve, and then it is having a reflex center. If there is lesion of afferent pathway, which is the optic nerve, then when light is shown into affected eye, then no response in both eyes. But when light is shown into normal eye, both eyes constrict followed by slight dilation, and this is called amblyopic light reaction or gun pupil. But if there is lesion of efferent pathway, that is lesion to oculomotor nerve, so when light is shown into affected eye, there is no response in affected eye, but the opposite eye constricts, and when light is shown into normal eye and affected eye shows no response, but normal eye constricts followed by slight dilation. Let's discuss about some abnormalities of pupil. The first one is Argyll-Robertson pupil. It occurs when there is lesion at the pretectal area of midbrain. Pupil is small and irregular. However, accommodation reflex is present, but light reflex is absent. The other abnormality of the pupil is called Holmes eddy pupil, and it occurs when there is peripheral disorder of autonomic nervous system. Mostly it occurs after viral infection, and it is benign, it is self-resolving. So there is lesion at the ciliary ganglion, and when there is paralysis of ciliary muscle, this is also called internal ophthalmoplegia. Pupil is large. Accommodation reflex is delayed and sustained. Therefore, it's also called tonic pupillary reaction. And light reflex is absent, accompanied with the absence of other deep tendon reflexes such as ankle jerk reflex. The other abnormality that you may see is in Horner syndrome. There is damage to postganglionic sympathetic fibers which arise from the superior cervical ganglion, and these fibers travel along the carotid and ophthalmic arteries and supply to dilator pupillae and tarsal muscle of upper eyelid and orbital muscle which holds the eyeball, and as well as supply to sweat gland of the face, especially forehead. So you can remember the signs of the Horner syndrome by mnemonic sample. So if the sympathetic nerve fibers which arise from the superior cervical ganglion is damaged, then it leads to anhidrosis, means no sweating of the face, especially forehead. There will be meiosis, means constriction of pupil, and there is ptosis, means drooping of upper eyelid, and as well as there is loss of ciliospinal reflex, means when neck or upper chest is pinched, normally there is ipsilateral dilation of pupil, but this reflex is lost in Horner syndrome. And then there is enophthalmos, means sinking of eyeball, because there is weakness of the extraocular muscles. And the last step that you have to do in the case of eye examination is ocular movement examination. Now, how you have to perform: with your one hand stabilize the patient's head and hold fingers 2 feet away and move it in these directions. I have already mapped it here for you. And when you reach at the extreme of the movement, keep it there for some time and check for nystagmus, restricted movement, diplopia, and if diplopia is present, ask at which direction diplopia is maximum. So some other causes of the extraocular muscle weakness can be myasthenia gravis, where there is antibodies against the acetylcholine or acetylcholine receptor at the neuromuscular junction. Extraocular muscle weakness can also occur in ocular myopathy and Wernicke encephalopathy, which is vitamin B1 deficiency. Now let's focus in this one. There are some causes of dilated pupil. For example, if there is bilateral dilatation of pupil, that can occur in anxiety. But if there is unilateral dilated pupil, it can be because of third nerve palsy or some medications like atropine and homatropine, which are cholinergic antagonists. And some causes of constricted pupil: if there is bilateral constricted pupil, it can be normal in old age, or it can occur in pontine lesion, or the patient has ingested opium. But if there is unilateral constricted pupil, it can occur in Horner syndrome or medication like pilocarpine, which are cholinergic agonists. So here you go, we are done with the three cranial nerves like oculomotor, trochlear, and abducent nerve. Now this is time to discuss about the trigeminal nerve or fifth cranial nerve. It has two parts: the motor part, which is supplied to masseter, temporalis, and pterygoid muscle, and the sensory part, which is divided into three divisions, and that's why it's called trigeminal. Let's now discuss the motor part in detail. The masseter and temporalis muscles elevate the jaw, and how you have to examine it: place your hands on sides of cheeks and ask the patient to clench his teeth, and you will feel the contraction of masseter and temporalis muscle. But if there is bilateral paralysis of masseter temporalis, then the jaw hangs loosely. When the pterygoids of both sides contract, they depresses and protrude the jaw, and if there is contraction of pterygoid muscle of a single side, then it pushes the jaw laterally towards the opposite side. And how you should examine it: examine the pterygoid of both sides by asking the patient to open his mouth against the resistance, and examine the pterygoid of one side by asking the patient to deviate his jaw towards you against the resistance. And evaluating the integrity of function of the motor part of trigeminal nerve, test the jaw jerk. Ask the patient to open his mouth and hang jaw loosely, and place your thumb over the chin and strike with clinical hammer. If there is brisk closure of jaw, then there is upper motor neuron lesion of the trigeminal nerve. Now the sensory part of the trigeminal nerve carries the sensation of touch, temperature, and pain. To examine pain, use the pin. To examine sensation of temperature, use two test tubes of hot and cold temperature. And for testing the touch sensation, use a piece of paper or piece of cotton cotton or piece of wool. Now, how you have to do it: first touch at his normal side so that he experiences what you mean by the sensation of touch, temperature, and pain. And then ask the patient to close his eyes and say yes when he feels it. And also say either the sensation is similar on both sides or not. And then examine the divisions, the sensory division of trigeminal nerve. There are three sensory divisions of the trigeminal nerve. The first one is ophthalmic division, the part above the line which is drawn from the tragus of the ear to outer canthus of the eye. Here you have to check the corneal and conjunctival reflex. The afferent limb of this reflex is made by the ophthalmic division of trigeminal nerve, while the efferent limb is made by the facial nerve. So ophthalmic division carries the sensation and the facial nerve causes the brisk closure of eyelid. So ask the patient to look medially, either blow from the lateral side or touch with the cotton. If the patient shows brisk closure of his eyelid, it means that the corneal and conjunctival reflex is intact. The maxillary division, the part above the line drawn from the tragus to the angle of mouth, and it includes gum, teeth, hard palate, soft palate of the upper jaw. And the mandibular division is all parts of the lower jaw except angle of mandible, because angle of mandible is supplied by the spinal segment C2. Now, what are the causes of the trigeminal nerve palsy? Cerebellum pontine angle tumor, which involves the trigeminal nerve, facial nerve, vestibulocochlear nerve, and cerebellum. The lesion that occurs in the cavernous sinus, which includes the ophthalmic division of trigeminal nerve, oculomotor nerve, trochlear nerve, and abducent nerve. And bulbar palsy, which leads to bilateral paralysis of muscles of mastication. And jaw jerk is brisk in pseudobulbar palsy. Trigeminal neuralgia, which is the most common disease of the fifth cranial nerve. If the cause is idiopathic, then it never involves ophthalmic division. But if the cause is known, such as multiple sclerosis, herpes zoster virus, which commonly affect ophthalmic division of the trigeminal nerve. So it was about the trigeminal nerve. Now let's talk about the seventh cranial nerve, which is facial nerve. It winds around the sixth cranial nerve nucleus, and then it goes into the internal acoustic meatus along with the vestibulocochlear nerve, and then enters the facial canal, which is present in the temporal bone of the skull, and then comes out of the skull through stylomastoid foramen. And under the parotid gland outside the skull, it divides into five motor branches, such as temporal branch, zygotic branch, buccal branch, marginal mandibular branch, and cervical branch. In the middle ear, it is supplied to stapedius muscle for dampening of the noise. It gives a sensory branch which is called chorda tympani to the anterior two-thirds of the tongue for taste sensation, and as well as it is supplied to the posterior wall of ear canal. And if there is loss of sensation of posterior wall of ear canal, this is called Hetzelberger sign. It also carries the parasympathetic fibers to lacrimal glands, submandibular gland, and sublingual salivary glands. Now let's know about the steps of examination of the seventh cranial nerve, which includes assessing the function of lacrimal gland, that is lacrimation test, evaluating the test of the patient from anterior two-thirds of the tongue, and assessing the acoustic reflex, and then evaluating the motor function of the facial nerve. So let's start with lacrimation test. For lacrimation test, perform two tests: Schirmer test and tear film breakup test. Schirmer test is used to measure the tear production. First, tell the patient you will place a special Schirmer strip paper inside his lower eyelid, and ask the patient to look upward and sit comfortably without blinking forcefully. Bend one end of the Schirmer strip and insert that bent end into the outer third of the lower eyelid, and then ask the patient to close his eyes gently for 5 minutes. And after 5 minutes, remove the Schirmer strip and then try to interpret it. If more than 15 millimeter of the Schirmer strip is wet, it is normal, but if less than 10 millimeter of the Schirmer strip is wet, so it means that the tear production is reduced or the patient is having dry eye. And how to perform the tear film breakup time? Instill fluorescence dye into the patient eye and then observe the tear film production using the slit lamp. Start counting until dry spots appear. If the dry spots appear after 10 seconds under the slit lamp with cobalt blue light, then it is normal. But if the dry spots appear before 10 seconds, this means that the tear production is being compromised. The next test is evaluating the taste sensation of the patient from anterior two-thirds of the tongue. Inform the patient that you will test 4 tests: sweet, salty, sour, and bitter. Tell them that they have to respond by raising fingers or writing on a piece of paper. For example, for sweet test, raise a single finger. For salty test, raise 2 fingers. For sour test, raise 3 fingers. And for bitter test, raise 4 fingers. Or you can write your response on paper. Then ask the patient to protrude his tongue and make sure that his mouth remains slightly open, and then hold the tongue with a clean and dry gauze to stabilize the tongue and prevent excessive movement. And before that, dry the surface of the tongue to prevent mixing of solution. And then evaluate either patient can appreciate the 4 tests or not. Then jump to acoustic reflex test, where you assess the integrity of function of stapedius muscle. Place tympanometer probe in the external auditory canal of the patient and it produces a loud sound. If the stapedius muscle is functional, then it contracts and tympanic membrane mobility decreases, which is being detected by tympanometer probe. But if the stapedius muscle does not contract, then the mobility of the tympanic membrane increases, and it means that the acoustic reflex is absent. So acoustic reflex arc consisting of cochlear nerve as an afferent limb and facial nerve as an efferent limb. After evaluating the acoustic reflex, jump to the motor test. First, general inspection. Check the palpebral fissure, nasolabial fold, and angle of mouth. Then ask the patient to wrinkle his forehead, and then ask the patient to close his eyes and open his eyes against resistance to check the power of orbicularis oculi. And if the patient is unable to close his eyes, then Bell's phenomenon appears, means there will be uprolling of eyeballs. Then ask the patient to inflate his cheeks, and the examiner will tap with his fingers and ask the patient to show his teeth, whistle, and pout his lips. Now, these all tests are performed in an conscious patient, but if the patient is unconscious, then deviation of angle of mouth is demonstrated when pressure is applied over supraorbital notch. Now, facial nerve palsy can be of 2 types: supranuclear facial palsy and infranuclear facial palsy. Supranuclear facial palsy is in fact the upper motor neuron lesion, which can be caused by stroke, trauma, multiple sclerosis, and tumor of the brain. And the lower motor neuron lesion of the facial nerve is called infranuclear facial palsy. It can be caused by Bell's palsy, which is reactivation of herpes simplex type 1 virus, and it damages the facial nerve in the facial nerve canal. Ramsay-Hunt syndrome is the reactivation of varicella zoster virus, which damages the geniculate ganglion of the facial nerve. The lower motor neuron lesion of the 7th cranial nerve can also occur due to inflammation and tumor of the parotid parotid gland, or there can be trauma to facial nerve during child delivery occurs by forceps. And if there is temporal bone trauma or otitis media, then it can damage the facial nerve at the stylomastoid foramen, which is present between styloid process and mastoid process. Infections like MUMP, mononucleosis, and Lyme disease can lead to lower motor neuron lesion, and surgery of the parotid gland and mastoid process can damage the facial nerve. And some diseases like sarcoidosis and diabetes mellitus can also lead to lower motor neuron lesion. Lesion at the cerebellopontine angle, then there also will be features of cerebellar dysfunction, trigeminal abducent, and vestibulocochlear nerve palsy along with the facial nerve palsy. And lesion at the pon leads to feature of 7th and 6th cranial nerve associated with the hemiplegia of the opposite side. Now let's know the signs and symptoms of the supranuclear and infranuclear facial palsy. In supranuclear facial palsy, there will be contralateral weakness on lower half of the face. Patient cannot smile, so mouth droops to the paralyzed side. Patient cannot fully open his mouth, so there is a flat nasolabial fold. Patient cannot wrinkle his forehead and raise his eyebrows, but patient can close his eyes, so Bell's phenomenon is absent. Patient has intact taste from it is anterior two-third of the tongue. Hearing is also not affected, means acoustic reflex is present, but there is increased facial reflexes. It means the facial reflex is elicited by tapping around the mouth, and there is no atrophy of the facial muscles. However, in the infranuclear facial palsy, there is ipsilateral weakness of the entire half of the face. Patient cannot smile, so there is mouth drooping. Patient cannot fully open his mouth. There is a flat nasolabial fold, and patient cannot wrinkle his forehead or raise his eyebrows. As well as Bell's phenomenon is present because patient cannot close his eye. Taste is also affected if the chorda tympani is involved, so there will be loss of taste from anterior two-thirds of the tongue. There will be ipsilateral hyperacusis because acoustic reflex is absent from the affected side, and normal facial reflexes but associated with the atrophy of facial muscles. Let's talk about the 8th cranial nerve, which is vestibulocochlear nerve. From its name, it is obvious that it is having two parts, cochlear part and vestibular part. For examination of the cochlear part, the first thing which you have to do is rule out local pathology of the external auditory canal by otoscope, and then perform the following tests to rule out the hearing abnormalities, starting with basic hearing tests, which include whisper test, watch test, and finger friction test. If you found any abnormalities in basic hearing test, then jump to tuning fork test. Now the principle of the tuning fork test is that the duration of sound heard through air conduction is more than that of bone conduction. For example, the sound which is being heard through the air conduction when the tuning fork is placed in front of the ear is 45 seconds, and the sound which is heard through bone conduction when vibrating tuning fork is placed on mastoid process is for 35 seconds. So for this test you have to perform first Rene's test and then Weber's test. So in the Rene test, the same, that air conduction is more than the bone conduction, and when the duration of sound heard through air is longer than that of sound heard through bone, then the Rene test is positive. In conductive hearing loss, bone conduction is more than the air conduction, so the sound duration which is being heard through bone conduction is more than that of air conduction, and this is called Rene negative. It suggests external or middle ear pathology like wax, otitis media, and ossicular fixation. And in sensory neural hearing loss, both air conduction and bone conduction are reduced, but still air conduction is a bit longer than the bone conduction, and this is called Rene reduced positive, and this indicates inner ear or auditory nerve pathology. pathology. False negative Rene, it occurs in severe unilateral sensory neural hearing loss. When the tuning fork is placed on mastoid of the affected ear, then sound is transmitted via skull bones to the normal ear, and patient reports hearing it. It appears like bone conduction is more than the air conduction, and it falsely suggests conductive loss. So it can be prevented by masking the opposite ear. When you perform the Rene test, now you can go towards the Weber's test. In the Weber's test, if there is conductive hearing loss, then sound is better heard in deaf ear. Why? Because there will be masking of environmental noise, sound is trapped in ear, and it leads to hypersensitivity of the inner ear. But if there is sensory neural hearing loss, then sound is better heard in healthy ear, and this is called lateralization because sound travels through the bones of skull towards the healthy ear. And you can also perform absolute bone conduction test where the examiner compares his hearing ability with the patient, knowing this that the examiner is having intact hearing. The second part of the earth cranial nerve is vestibular part. To assess the integrity of function of the vestibules, we perform caloric stimulation test, rotation chair test, and then if patient is having nystagmus or vertigo, then we have to go for its diagnosis and treatment. For caloric test, we have a mnemonic that's called COWS, means cold towards the opposite, warm towards the same direction. How you have to perform: cold water is instilled into the ear and eyes slowly drift towards the irrigated ear, and then there is a fast correction movement away from the irrigated ear. On the other hand, when warm water is instilled into the ear, then eyes slowly drift away from the irrigated ear and fast correction movement is towards the irrigated ear. That's why there is a mnemonic COWS, which means cold towards the opposite side and warm towards the same side. Then there is another test which is called rotation chair test to assess the function of horizontal semicircular canal and vestibulo-ocular reflex and bilateral vestibular weakness. So the steps of rotation chair test is being mentioned in this image. Second is for diagnosis and treatment of benign paroxysmal positional vertigo or positional nystagmus. We can perform Dix-Hallpike maneuver or supine roll test for diagnosis, and for treatment there are pharmacological treatment such as by giving beta-histamine dihydrochloride, which is 16 mg, or prochlorperazine 5 mg, but it can also be treated with the help of Apley maneuver. So now steps of Hallpike maneuver. It is used for diagnosis of the benign paroxysmal positional vertigo. First, we ask the patient to sit upright, and then the doctor rotates the patient head 45 degrees towards the side being tested. While supporting the head, the doctor quickly brings the patient from sitting into lying position in such a way that the head hangs 20 to 30 degrees below the level of the table, and then the doctor observes for any positional nystagmus or vertigo. If the patient experiences vertigo or the doctor notices positional nystagmus, then benign paroxysmal positional vertigo is diagnosed. Now when it is being diagnosed, you can as well as treat it on the bedside, and this is called Apley maneuver. It helps to move loose crystals through the semicircular canal back into your ventricle where they stop causing vertigo. You ask the patient to sit upright, turn head 45 degrees towards the affected ear, and then quickly lie back head in such a way that it hangs 20 to 30 degrees below the level of the table, and then keep the patient in that position for 30 to 60 seconds. Then turn the patient's head 45 degrees towards the healthy ear, and then stay like this for 30 to 60 seconds, and then ask the patient to roll onto the side in such a way that nose is down, and stay like this for 30 to 60 seconds, and then ask the patient to sit up slowly, keep the chin slightly tucked, and in this way, when the position is maintained, the paroxysmal positional vertigo is treated. However, symptomatic Systematically, you can give some medicines, as I have already mentioned, like beta histamine and prochlorperazine 5 milligram. The ninth cranial nerve is glossopharyngeal nerve, and it arises from medulla and comes out through the jugular foramen and supplied to a muscle which is called stylopharyngeus muscle, and its sensory supply is to the posterior one-third of tongue, tonsillar region, pharynx, soft palate, tympanic cavity, and eustachian tube, and its parasympathetic fibers are supplied to parotid gland. And the integrity of function of ninth cranial nerve, which is glossopharyngeal nerve, can be assessed by eliciting palatal reflex or gag reflex. In the palatal reflex, the reflex arc is made by two nerves, which are ninth cranial nerve, which makes the afferent limb, and vagus nerve, which makes efferent limb. So touch the soft palate in each side separately to observe the contraction. If the soft palate contracts, it means that the palatal reflex pathway is intact. And similar way, gag reflex pathway is also used to evaluate the integrity of function of glossopharyngeal nerve. Touch with the help of cotton or wool the posterior pharyngeal wall and each side separately, and if there is contraction, it means that the reflex pathway is intact. In the gag reflex, the efferent pathway is vagus nerve and afferent pathway is glossopharyngeal nerve. The 10th cranial nerve is called vagus nerve. The motor component arises from the nucleus ambiguous and comes out through the jugular foramen and supplied to muscles of larynx, soft palate, and pharynx. As you see in the image, the muscles of soft palate include levator veli palatini, platoglossus, palatopharyngeus, and musculus uvula. However, the tensor veli palatini is being supplied by mandibular branch of the trigeminal nerve, and the muscles of pharynx include superior constrictor, middle constrictor, inferior constrictor, and salpingopharyngeus. And stylopharyngeus muscle, we know that it is being supplied by glossopharyngeal nerve, which is the ninth cranial nerve, and the muscles of larynx, which is supplied by recurrent laryngeal nerve, are posterior cricoarytenoid, lateral cricoarytenoid, transverse arytenoid, oblique arytenoid, thyroarytenoid, and vocalis. And the muscles of upper esophagus is striated muscle of upper esophagus, which is supplied by recurrent laryngeal nerve. So these are the muscles which are being supplied by the motor component of vagus nerve. And also note that there are parasympathetic fibers of the vagus nerve, but they are supplied to the organs of chest and abdomen. And unilateral damage to vagus nerve occurs during thyroid surgery, and the most vulnerable nerve during thyroid surgery is recurrent laryngeal nerve. But if there is bilateral damage to vagus nerve, this is because of bulbar or pseudobulbar palsy. Now, how you have to test the vagus nerve? Ask the patient to cough to see the nasal quality. Ask the patient to open his mouth and say observe the movement of posterior pharyngeal wall, and if there is paralysis and the paralysis is unilateral, then wall move laterally towards the normal side like a curtain, and observe the movement of soft palate. If paralysis is unilateral, soft palate remains immobile and uvula moves laterally towards the normal side. Ask the patient to puff out cheeks. If there is paralysis of soft palate, then air escapes from the nose, and then ask the patient to drink water and observe nasal regurgitation or difficulty swallowing, which is called dysphagia. Now it is time to talk about the 11th cranial nerve, which is called accessory nerve. Now this nerve is also having two parts, spinal part and cranial part. Spinal part arises from the spinal cord segment from the C1 to C5 or C6, and it enters skull through foramen magnum and exits through jugular foramen, and it is supplied to to sternocleidomastoid and trapezius muscle, while the other part of the accessory nerve is the cranial part, which arises from a part of medulla which is called nucleus ambiguus, and it joins the vagus nerve and innervate the structures which are innervated by vagus nerve, like muscles of soft palate, muscles of pharynx, except stylopharyngeus muscle, and all intrinsic muscles of larynx. For examination of sternocleidomastoid, ask the patient to bend head downwards against the resistance to check the power of the sternocleidomastoid. And if you want to check the sternocleidomastoid unilaterally, then ask the patient to turn head left or right against resistance. Then examination of trapezius muscle. First, inspect the patient from behind. If the trapezius muscle is paralyzed, then upper part of scapula is displaced away from spine and lower part of scapula is displaced towards the spine and the arm droops. Then ask the patient to shrug shoulder against resistance to check the power of the trapezius muscle. Now the last cranial nerve, which is the 12th cranial nerve, it is hypoglossal nerve. It arises from medulla and exits skull through hypoglossal canal. In bilateral upper motor neuron lesions such as pseudobulbar palsy, tongue looks small, conical, and immobile. In unilateral upper motor neuron lesions, when tongue is protruded, it deviates towards the paralyzed side. And in bilateral lower motor neuron lesions such as bulbar palsy, there is bilateral vesting and fasciculation. In unilateral lower motor neuron lesion, there is unilateral vesting and fasciculation. So hypoglossal nerve is supplied to all intrinsic and extrinsic muscles of the tongue except palatoglossus muscle, which is supplied by 10th cranial nerve, that is vagus nerve. So how you have to perform the examination of the 12th cranial nerve? Ask the patient to open his mouth and inspect the tongue for its size, shape, vesting, and fasciculation. Ask the patient to protrude his tongue and note any deviation. Ask the patient to place finger on the cheeks to check the power of the extrinsic muscles of tongue. Damn, the cranial nerves had been so lengthy. I promise you, this is the last one. There are some muscles whose line of action is towards the opposite side, and when they are paralyzed, the unopposed muscle push the body towards the affected side. Like normal function of sternocleidomastoid is ipsilateral flexion and contralateral rotation of the head. Now, if sternocleidomastoid is paralyzed, the head is turned towards the affected side. The normal function of the genioglossus muscle is to push tongue towards the opposite side or to protrude the tongue. If it is paralyzed, tongue deviates towards the affected side. And the normal function of the pterygoid muscle is to push jaw to opposite side. When they are paralyzed, jaw is deviated towards the affected side. So I think you should remember them because these are very, very confusing for most of the medical students and medical professionals. Let's now learn the motor system examination. In motor system examination, we need to measure bulk of muscles, tone of muscles, and power of muscles. Then we need to elicit reflexes, which are superficial and deep reflexes. Then we have to look at the gait of the patient and some involuntary movements, and then we need to check coordination of movements to find out the cerebellum function. So let's start with measuring bulk of muscle. If the bulk of muscle reduces, this is called atrophy, and it's caused by lower motor neuron lesion, cachexia due to chronic systemic illness, or disuse atrophy due to some joint problems. And if the bulk of the muscle increases, this is called hypertrophy. So if the power and as well as bulk increase, so it can can happen in athletes and or myotonic dystrophy. But in muscular dystrophy such as Duchenne or pseudohypertrophy, the bulk of the muscles increases but the power decreases. There are two common terms that you should have knowledge about. They are fasciculation and fibrillation, and they are found in upper motor neuron lesions. Fasciculation is fine, flickering, and irregular twitching of group of muscle fibers. However, fibrillation is fine, flickering, and irregular twitching of single muscle fiber. So, this group of muscle fibers are innervated by a single motor neurons, and it occurs because of nerve irritation or hyperexcitability, and fasciculation is visible with naked eyes. On the other hand, the flickering movement which is produced by a single muscle fiber is because of losing its connection with its motor neuron, and it is only visible under electromyography. So how do you measure the bulk of muscle? The first step is inspection of both upper limbs and lower limbs when patient is fully exposed. Second, check for fasciculation under adequate light and keep the muscles completely relaxed. Third, measure the bulk of muscles of forearms. How do you do it? Measure from the styloid process to point where muscle bulk is maximum, and note the distance and circumference, and then measure the circumference of the next arm at the same distance. And how to measure the bulk of muscles of upper arms? Mark the midway between acromion process and olecranon process of ulna, and then flex arm 90 degree and measure the circumference, and measure the circumference of the other limb exactly at the same distance from the olecranon process. For measuring the muscle bulk of leg, you need to take distance from medial malleolus to the point where muscle bulk is maximum, and then note the distance and circumference, and measure the circumference of the next leg at the same distance from medial malleolus. For muscle bulk of thigh, measure from lateral condyle of tibia to point where muscle bulk is maximum, and then note the distance and circumference, and then measure circumference of the next thigh at the same distance from the lateral condyle of tibia and compare them together. This is how you may measure the muscle bulks of upper limbs and lower limbs. Now it is time to measure the tone of muscles. Now what is tone of muscle? The resistance felt when joint is moved passively is called tone of muscle. Now tone of muscles can either be increased, which is called hypertonia, or can be decreased, which is called hypotonia. And hypertonia is of two types. If you experience resistance initially, which increases, and then suddenly the resistance decreases, this is called clasp knife spasticity, because it resembles the clasp knife and is found in upper motor neuron lesion. The other type of the hypertonia is rigidity. There is gradual increase in resistance throughout the range of the passive movement, like bending a lead pipe. So that's why it's also called lead pipe rigidity, and it's found in basal ganglion lesion. But if there is gradual increase in resistance throughout the range of passive movement, but jerkily, like slipping of rackets over the teeth of a cog, this is also called cogwheel rigidity, and is found in Parkinsonism. If the rigidity resembles lead pipe rigidity, but resistance increases proportionally to amount of force applied to perform passive movement, this is called hysterical rigidity or psychogenic rigidity, which may be because of conversion disorder. So there is no organic cause for the hypertonia. When the tone of the muscles decreases, this is called hypotonia. So it is found in lower motor neuron lesion of sensory pathways, neuronal or spinal shock, and cerebellar dysfunction. Now, how to examine the tone of muscle? You need to carry out full range of passive movements at the wrist, elbow, hip, knee, and ankle joints. First rapidly and then slowly to assess the resistance encountered during during movement. And here you can see either the tone is normal or increased or decreased. Grasp the patient's forearm and shake it. Observe the movement and tone around the wrist. Grasp the patient's lower limb below the knee and move it from side to side to observe the movement and tone around the ankle. So this is how you examine the tone of muscles. Now let's know about the power of muscles. Muscles are having 5 powers. Grade 1, there would be only flickering. In grade 2, patient is able to move his limbs horizontally, means excluding the gravity. Grade 3 is that patient can move his limbs vertically against the gravity. Grade 4 is when patient is able to move his limbs against resistance which is applied by the examiner. And grade 5 is normal strength or normal power, as you see in the image as well. Now remember one thing, that the muscles can either completely lose its function, which is called aphasia, or there would be decrease in the strength of the voluntary muscles, which is called paresis. If there is hemiplegia, which means either weakness or paralysis of one upper and one lower limb of the same side of the body, or this can be uncrossed hemiplegia, means there is cranial nerve paralysis and hemiplegia which are on the same side of the body, and this can be crossed hemiplegia or crossed hemiparesis, means that the cranial nerves are paralyzed on one side while hemiplegia is on the other side opposite to the cranial nerve paralysis. Monoplegia means weakness or paralysis of one limb only, means a single limb is paralyzed. Paraplegia means weakness of both lower limbs. And quadriplegia, which is also called tetraplegia, which is the paralysis of all 4 extremities. So it can be quadriplegia or quadriparesis. Quadriparesis is the weakness. On the other hand, quadriplegia is complete loss of voluntary movements. Let's now assess the strength of upper limb muscles, starting with abductor pollicis brevis. It is supplied by median nerve. So you need to instruct the patient to abduct the thumb at a right angle to the palm against the resistance, as you see in the image. The next muscle of the upper limb is opponens pollicis. It is supplied by the median nerve. You need to ask the patient to touch the little finger by his thumb and make a loop, and the examiner tries to separate them, or instruct the patient to touch the base of the little finger with thumb and the doctor tries to separate them apart, as you see in the image. Assessing the strength of abductor pollicis brevis, which is supplied by ulnar nerve, you need to instruct the patient to adduct the thumb towards the palm of the hand against the resistance, or ask the patient to hold book between clenched fingers and extended thumb, as it is shown in the image. Lumbricals. First and second lumbricals are supplied by the median nerve, while third and fourth lumbricals are supplied by ulnar nerve. You have to instruct the patient to flex the metacarpophalangeal joints and extend the interphalangeal joints against resistance, as shown in this image. The next muscles that we need to assess the strength is interossei, which is supplied by ulnar nerve. Palmar interossei adduct the fingers, and mnemonic for this is pad, and dorsal interossei abduct the fingers, and mnemonic for this is dab. To test the palmar interossei, you instruct the patient to spread the fingers against the resistance, and to test the dorsal interossei, ask the patient to hold card between 2 fingers or move the fingers towards the midline. For the flexors of the finger, instruct the patient to squeeze the fingers of the doctor while he pulls to free them, as you see in the image. For the extensors of the finger, ask the patient to open the fist against the resistance, as you see in the image. For the flexors of the wrist, ask the patient to bring tips of his fingers towards the front of his forearm against the resistance. And for the extensors of the wrist, ask the patient to make fist and flex the fist against the resistance, as you see in the image. For assessing the strength of brachioradialis, instruct the patient to flex the elbow against the resistance while arm is in midway between supination and pronation. For checking the strength or power of the biceps, ask the patient to flex fully supinated arm against the resistance. And for checking the tricep, ask the patient to extend the flexed forearm against the resistance. And for assessing the power of deltoid, check anterior, middle, and posterior deltoid separately. As you see in the image, the examiner pushes backward to check the anterior deltoid while asking the patient to resist the motion. In the next image, you see that the examiner is trying to push the arm downward to check the middle deltoid while the patient is applying resistance to the motion. And in the third image, you see that the examiner is trying to push the arm forward to check the posterior deltoid while the patient is applying resistance to the motion applied by the examiner. For assessing the strength of supraspinatus, ask the patient to abduct the arm against the resistance. Always remember that the first 30 degree is carried out by supraspinatus, while the next 60 degree abduction is carried out by deltoid. Checking the power of the serratus anterior, instruct the patient to push against the wall. If the serratus anterior is paralyzed, there will be winging of scapula and the patient will be unable to elevate arm above the right angle, means above the 90 degree. Now let's check or assess the power of the muscles of lower limb. Ask the patient to do the dorsiflexion, plantar flexion of the toes and foot, along which also ask him to do the eversion and inversion of the foot, and then examine the extensors of the knee, flexors of the knee, extensors of the hip, flexors of the hip, and abductor and adductor of thigh. Use the visual aids provided to guide the patient through each movement, ensuring you apply resistance at each step. Assessing the strength of muscles of trunk, ask the patient to lift his head up against the resistance, and when the patient tries to lift up his head, the abdominal muscles contract. But if the muscles of upper abdomen is paralyzed, the umbilicus moves downward, and if the muscles of lower abdomen is paralyzed, the umbilicus moves upward, and this is called beaver sign, as you see in the image. So we are done with measuring power and bulk of the muscles. Now it is time to study about the reflexes, since you know that there are two types of reflexes: superficial and deep tendon reflexes. The reflex arc of the deep tendon reflex is shown in the image. There is muscle spindle which detects the stretch, and the afferent limb is IA fibers which carries it to a particular spinal segment, or which is also called reflex center, and there is only one single synapses, so that's why it's called monosynaptic. Then efferent fiber comes out of the anterior gray horn, which is called alpha motor neuron, and it is supplied to the same muscle which is being stretched. As you see, the reflex with it is root value. For ankle jerk, the root value is S1 and S2. For knee jerk, the root value is L3 and L4. For biceps, the root value is C5 and C6. For the triceps jerk, the root value is C6 and C7. For the brachioradialis jerk, the root value is C5 and C6. For the plantar reflex, which is the superficial reflex, the root value is S1. Abdominal reflex is T8 and T12. For the cremasteric reflex, the root value is L1 and L2. And for the anal reflex, the root value is S3 and S4. And for conjunctival and corneal reflexes, the root value is cranial number 5, which is trigeminal nerve, and facial nerve, which we have already discussed about this. So for ankle jerk, you need to strike the Achilles tendon, and for knee jerk, strike between patella fibula and tibial tuberosity. For biceps jerk, keep the arm in semi-pronated position. Place your thumb on biceps tendon in cubital fossa and then strike on your thumb. For brachioradialis jerk, which is also called supinator jerk, place the arm in semi-pronated position and strike above the styloid process of radius. For triceps jerk, strike the tendon above the olecranon process. Now, there is one ankle clonus or patellar clonus. Sudden stretch of the muscle produces involuntary oscillatory muscular contraction and relaxation. Always know if the clonus is sustained, then it may be because of upper motor neuron lesion, but if it is ill sustained, then it can be because of anxiety. I have provided you the illustrative guidance for each deep tendon reflexes as you see in the image. If the deep tendon reflexes are not so prominent and obvious, then you can perform Gendrasik maneuver. This is for the reinforcement of the reflexes. The purpose of this is to distract the brain and get stronger reflexes. You can perform Gendrasik maneuver in two ways. Either ask the patient to clench his teeth while you are trying to elicit the reflexes, or you can ask the patient to hook his fingers together and pull them apart when you elicit the reflex. So in this way, the reflexes are exaggerated. Why? Because the brain is distracted. So we are done with the deep tendon reflex. Now let's study the superficial reflexes. The reflex arc is shown in the image. The receptors are present in the skin or mucosa. The afferent limb is made up of A delta or sometimes A beta fibers. In the spinal segment or in the reflex center, there are multiple synapses of interneurons. So that's why it's called polysynaptic. And the efferent fiber is made up of alpha motor neuron, which arises from anterior gray horn and then supplied to muscle, a particular muscle, to contract. The superficial reflexes are abdominal reflex, anal reflex, bulbocavernous reflex, cremasteric reflex, and plantar reflex. I have provided you illustrative guidance for these superficial reflexes. There is an interesting fact about the plantar reflex. Now, if the plantar reflex is upgoing, which we call it that the Babinski sign is positive, then it can be because of upper motor neuron lesion, hypoglycemia, deep coma, or post-epileptic fit, and it is normal in infant. If the plantar reflex is absent, then it can be because of cold feet or loss of S1 dermatome or spinal shock or paralysis of muscles of big toe. Hysterical paralysis, which may be psychological, like a patient having conversion disorder. You need to use the following maneuvers to differentiate between psychogenic weakness and true organic paralysis. These maneuvers are Hoover sign, wheelchair sign, Rossolemos sign, and finger flexion sign, as I have provided you some visual aids to understand these maneuvers so that to differentiate between organic and non-organic causes of the paralysis or paresis. Now let's interpret the reflexes. Let's know about the upper motor neuron lesion and their clinical pictures. When there is upper motor neuron lesion, the muscle tone increases, so there will be spastic paralysis. The muscle bulk is normal. Deep tendon reflexes are exaggerated. There's a unique feature which is called positive Babinski sign, as we already studied that when the plantar reflex is upgoing, it's called positive Babinski sign, since it is found in the lower limb. In the upper limb, similar to Babinski sign, is Hoffman sign. So when the Hoffman sign is positive, it shows that there is upper motor neuron lesion of the upper extremities. So the clinical pictures of the lower motor neuron lesions are that deep tendon reflexes are either absent or diminished. Muscle bulk decreases. The unique feature of the lower motor neuron lesion is fibrillation and or fasciculation. Fibrillation is not visible with naked eyes, but fasciculation is visible with naked eyes, which are fine flickering slurring, and irregular twitching. In the upper motor neuron lesion, we saw that the muscle tone increases, but in lower motor neuron lesions, the muscle tone decreases and the patient will have flaccid paralysis. So there is one question, that what is the unique feature of upper motor neuron lesion of upper limb, since the unique feature of the lower limbs had been positive Babinski sign. So this is Hoffman sign. How do you trigger it? Flick the middle finger and index finger and thumb come together. Now following is found when corticospinal lesion is widespread and severe, which are open hem reflex and Gordon reflex. Open hem reflex is triggered by stroking of anteromedial tibial surface, and the response is positive Babinski sign, means upgoing plantar reflex, and this occurs when there is upper motor neuron lesion, specifically pyramidal tract lesion. Gordon's reflex is produced when the calf is squeezed firmly, and it produces a positive Babinski sign, and this indicates upper motor neuron lesion, specifically pyramidal tract lesion. Now there is another amazing sign. When patient tries to touch the chest with his chin, electric shock radiates down the spine, arms and legs, and this is called Lermite sign or barber's chair sign. This is found in multiple sclerosis, vitamin B12 deficiency, syringomyelia, and cervical spondylosis. There is one more abnormality of the deep tendon reflexes, which is called inversion of reflexes. Now when there is damage to primary reflex arc, then reflex is produced by adjacent spinal segment because of loss of inhibitory supraspinal control. Why? Because now there is involvement of upper motor neurons. For example, there is lower motor neuron lesion at the same level, then there is upper motor neuron lesion above or below the same level. So these neurons has lost their inhibitory supraspinal control, and that is why they produces reflex instead of the primary reflex arc. So what will be the result? Expected reflex does not occur. Instead, an opposite or different movement is produced. For example, tapping the brachioradialis causes flexion and supination. There is another clinical picture related to deep tendon reflexes, which is called crossed extensor reflex or Sherrington reflex. In this, what happens that there is contraction of ipsilateral flexors and relaxation of the extensors. On the other hand, there will be contraction of contralateral extensors and relaxation of the flexors. This indicates a loss of normal descending inhibition from the brain. And remember, if you strike and the strike produces jerk contralaterally, then it is a sign of spinal cord lesion. So here our motor system examination ends. Now let's go towards the cerebellum examination, and if there is any dysfunction or the integrity of the function of cerebellum is compromised, then a specific sign appears, which is called cerebellar signs, and it indicates towards cerebellar dysfunction. But before studying the cerebellar signs, we should know a little about the cerebellar function, and it is anatomy. Vermis is important for maintenance of body posture, and body posture is maintained by axial skeleton, and as well as vermis plays a role in maintaining equilibrium of body. So if vermis is damaged, coordination is normal, but patient falls when tries tandem gait. The cerebellar hemisphere is important for smoothing and synchronizing the timing of muscle contractions and relaxation. If there is damage to cerebellar hemisphere, then it leads to nystagmus, intention tremor, dysdiadochokinesia, and coordination is also abnormal. So during examination of the cerebellum, check for nystagmus, scanning speech, intention tremors, and then assess the coordination of the muscles when the patient tries to move his limbs. For perfect coordination, following must be in intact: cerebellar system, motor and sensory system. Loss of coordination is called ataxia due to cerebellar or sensory loss. That is, sense of position is being lost, so the patient will lose his coordination as well. Coordination cannot be tested if the motor system is impaired. How can you ask the patient to walk when he is already having paralysis, right? So motor system must be intact so that you should know the coordination of muscles. Coordination is tested by finger nose test, finger to finger test, heel to knee test, heel to toe test, which is also called tandem gait, as you see in the image. Now, how to differentiate between a cerebellar and sensory ataxia? Cerebellar ataxia is unsteady. Either your patient's eyes are open or closed. But in sensory ataxia, patient is steady when eyes are open and becomes unsteady when eyes are closed. For these to differentiate between cerebellar ataxia and sensory ataxia, we have to look for the Romberg sign. We ask the patient to stand and close his eyes and observe either the patient becomes unsteady when he closes his eyes or not. So when you are done with assessing nystagmus, scanning speech, intention, tremors, and coordination, then you need to ask the patient to perform rapidly alternating movements. If the patient is not able to do this, this is called dysarthria. And the sixth one is rebound phenomenon. Check for the function of antagonist muscles. Seventh one is the pendular knee jerk, and it is found when there is damage to cerebellum. And then check the tone of the muscle. Normally, if the cerebellum is damaged, the muscle tone decreases. And then test for drunken gait, wide base gait, and ataxia. So for assessing the integrity of function of cerebellum, you need to check nystagmus, scanning speech, intention, tremors, coordination, dysdiadochokinesia, rebound phenomenon, and pendular knee jerk, and as well as check the tone and gait of the patient. Let's know what clues we can find in the style of the walking of patient which may point out towards specific abnormalities. There are 5 types of gaits. Let's start with spastic gait. Patient can't lift his feet from the ground completely, and the toes remain in contact with the ground, and leg is swung outward in circular fashion, and this is found in upper motor neuron lesion. The next one is high stepping gait. There is weakness of extensors and foot drops, and patient lifts the foot high to clear the toes from the ground and then returns it back with a loud slapping noise. Drunken gait. Well, this is present in the cerebellar dysfunction. Patient walks on a broad base and staggers towards the affected side, and it is found in the cerebellar lesion. Waddling gait. Body sways from side to side, and it's found in proximal muscle myopathies and congenital dislocation of hip joints. In Parkinsonism, there are 2 types of gaits: shuffling gait and fascinating gait. The Parkinson patient bends forward with flexion at hips and knees. Arms are adducted and flexed at the elbows with no association with walking movement. So walk is slow with short rapid steps, and feet are dragging along the floor, and this is called shuffling gait. As the upper body is bent forward ahead of the feet, so speed is increased in an attempt to maintain an upright posture, and this is called fascinant gait. Now let's talk about some involuntary movements. The first one is physiological tremor. It is a normal fine tremor which is present in everyone, but it is exaggerated by anxiety, thyrotoxicosis, caffeine, or salbutamol ingestion or administration. The second involuntary movement is called familial tremor or essential tremor. It is an autosomal dominant which is caused by cerebellothalamic circuit dysfunction, such as damage of dentate nucleus, thalamus, or motor cortex. Third involuntary movement is senile tremor. There is degeneration of cerebellar pathways with aging, which leads to tremor. Parkinsonian tremor or resting tremor, which is also called peel rolling tremor, and it is found in Parkinson disease. Intention tremor. Tremor is either absent or little when the patient is at rest, and tremor worsens turns as the patient tries to reach the target. Next is flapping tremor, which is also called asterexis. It is a negative myoclonus, means there is a brief loss of tone, and it's found in hepatic encephalopathy, uremia, carbon dioxide retention, but this tremor is not rhythmic. Titubation, head and trunk tremor due to Vermes lesion of the cerebellum. Tics, which is also called habitispasm, it is a sudden repetitive movements or sounds, and it is seen in Tourette syndrome due to high dopamine in basal ganglion. The next involuntary movement is coriform movement. It is brief, irregular, dance-like movement due to lesion in caudate nucleus, and it is seen in Huntington disease, rheumatic fever, which is also called sedentary chorea. Myoclonus jerks are sudden, brief, shock-like contraction, and it is seen in epilepsy and metabolic disorder. Athetioid movement is slow rhythmic movement due to potamen lesion, and hemibellismus is a violent fleeing movement on one side due to lesion of subthalamic nucleus. And the last involuntary movement is dystonic movement or torsion spasm, which is a sustained abnormal posturing. So here you go, we are done with the motor system examination. Now let's start the sensory system examination. There are two types of sensation. One is called primary sensation and other is called cortical sensation. The primary sensations include touch, pain, temperature, position, and passive movement and vibration. And cortical sensation involves localization, 2-point discrimination, and it's done with a calibrated divider. Graphesthesia, patient is unable to identify an object after careful palpation with closed eyes. Graphesthesia, patient is unable to recognize a number drawn on palm with blunt object. Perceptual rivalry, which is also called sensory extension or sensory inattention. Examiner touches corresponding parts of the body on both sides separately, and the side opposite that of parietal lobe damage will be ignored. And there are four terms that you should have knowledge about. Agnosia means inability to recognize familiar objects. Visual agnosia means inability to recognize familiar objects while vision is normal. Tactile agnosia is unable to recognize objects by palpation with both hands. If it is bilateral or if there is bilateral stereognosis, then lesion is in parietal lobe. Ataxia is inability to perform learned acts due to lesion in dominant parietal lobe, such as combing, drying square, and doing common household activities. And one should note that before testing for cortical sensation, make sure the patient is mentally alert and has normal speech and his primary sensations are intact. So if you want to test the cortical sensation, for that the primary sensations must be intact, otherwise you will never test the cortical sensations. We start the sensory system examination by explaining the procedure to the patient and taking informed consent. One should know that a sensation can be either lost, which is called anesthesia, or decreased, which is called hypoesthesia, or increased, which is called hyperesthesia. The examiner must apply stimulus to normal site of the patient so that the patient should experience the normal sensation, and ask the patient to close his eyes and raise his fingers or say yes when he feels the stimulus. For pain, use disposable pin or hypodermic needle, and this gives a sharp sensation. For touch, use cotton, wool, piece of paper, or monofilament. When monofilament is pressed against the skin, it transmits 10 grams of weight, and this is for blunt sensation. For temperature, use 2 test tubes containing hot and cold water. For deep pain, squeeze the muscle or tendons to a point it becomes painful. For sense of position and passive movement, ask the patient to close his eyes, and then examiner moves his limb, toes, or fingers in random directions and then place it in a particular position, and then asks him to imitate the position with other limb, toe, or finger. For sense of of vibration, use tuning fork of 128 Hz, place it on bony prominence such as terminal phalanx of toe or finger, lateral malleolus, shin, tibial tuberosity, iliac crest, costal margins, wrist, elbow, while sometimes still and sometimes vibrating, and ask the patient to differentiate it. For sense of location, ask the patient to close his eyes and then examiner touches his body and then ask him to open his eyes and place his finger on that part which is being touched by the examiner. For 2-point discrimination, use calibrated divider and ask the patient at how many sides he is being touched. For stereogenesis, ask the patient to close his eyes and give him an object like coin, key, and ask him to identify it after careful palpation. For graphesthesia, ask the patient to close his eyes and draw a number on the patient's palm and ask him to recognize it. For perceptual rivalry, ask the patient to close his eyes and touch corresponding parts of the body separately and simultaneously and observe either he ignores it or appreciates it. Here I have provided you the image of myotomes and dermatomes. Myotomes and dermatomes are ways the body maps out nerve. Myotome is group of muscles controlled by single muscle nerve root, and dermatome is area of skin supplied by sensory fibers from single nerve root. So you should learn the dermatomes and myotomes root values by heart. So we are almost at the end of the central nervous system examination course, and but there are some miscellaneous tests that we should know. We should learn about the signs of meningeal irritation, signs of root irritation, and Breuer during auscultation of neck and head can point out some abnormalities related to CNS. Then look for signs pointing towards the tetany, and then at the end we perform the examination of autonomic nervous system. So now let's start with the signs of meningeal irritation. When the meninges are irritated because of meningitis, then you will be able to find neck rigidity, Kernick sign, and Brudzinski sign. For assessing the neck stiffness, ask the patient to lie down and rotate his neck left and right and touch his chest by his chin. And for assessing neck rigidity, put one hand on the chest of the patient and other hand behind the head and lift up the head. For Kernick sign, bend the hip and knee 90 degree and then extend the knee and watch other knee for flexion because patient may feel pain and may flex his other knee. Brudzinski sign, both knees are extended and head is lifted up, and then watch for flexion of both knees. As you see in the image, when knee is flexed 90 degree and as well as hip is flexed 90 degree, then extension of knee is painful or limited in extension. In Brudzinski sign, the passive flexion of neck elicits hip and knee flexion. So now the second thing is signs of root irritation, that is which indicate sciatic nerve root lesion. Perform the straight leg raising. When you perform the straight leg raising, there is pain in the hamstring muscle when knee is fully extended. Then auscultate the neck and cranium. You may hear brew. Now brew is low continuous rumbling sound and it is produced because of turbulent blood flow. If brew is heard at the angle of jaw, this can be because of stenosis at the bifurcation of carotid artery, and if brew is heard at the supraclavicular fossa, then it may indicate stenosis of vertebral or subclavian artery. If you hear brew at the anterior border of sternocleidomastoid, this may point out stenosis of common carotid artery. But if one common carotid artery is completely blocked, then brewery at opposite side is due to increased blood flow. If brewery is heard at closed eyelid, it can be because of cerebral arteriovenous malformation. Then you have to rule out tetany. Tetany is caused because of hyperexcitability of neurons, and the hyperexcitability of neurons is caused by hypocalcemia or for alkalosis, because when there is alkalosis, there is shift of calcium from serum to albumin, or magnesium deficiency, because magnesium acts as a calcium channel blocker. If patient has hyperexcitability of neurons, then two signs may become positive. One is called Trozu sign and other is Chvostek sign. You can remember it in this way. The T in Trozu stands for tourniquet. When tourniquet is tied, it creates latent tetany, and this tetany causes carpal spasm, which is the flexion of wrist and curling of fingers, as you see in the image. Chvostek sign, C in Chvostek, shows chick, that is tapping 3 to 5 centimeter in front and below the ear, and this produces twitching of the orbicularis oris, as you see in the image. Then the last thing that we have to do is examination of autonomic nervous system. Check light reflex and accommodation reflex. So far we are done with them. Check the skin for sweating. Lack of sweating is feature of autonomic dysfunction. Check pulse rate. Tachycardia at rest is feature of autonomic dysfunction. Check pulse rate during deep inspiration. Absence of this is feature of autonomic dysfunction. Check blood pressure of patient after 15 minutes who is comfortably lying on the couch, and then ask him to stand up after 15 minutes and check his blood pressure after a minute, and then after 3 minutes. If the fall is more than 20 mm of mercury, then postural hypotension is present, which is a feature of autonomic dysfunction. Ask the patient to perform Valsalva maneuver, and normally during the Valsalva maneuver pulse rate falls, but if the pulse rate doesn't fall, this is a feature of autonomic dysfunction. Thank you for staying with me throughout this detailed CNS examination lecture. I truly appreciate your time and dedication in watching this full session. If you found this video helpful, don't forget to subscribe to the channel for more high-yield medical contents. If you have any questions or need clarification on any topic, feel free to ask in the comments. I will be happy to help. For those interested in accessing the complete HD PDF notes of this lecture, you can download them from Gumroad. Thank you once again for your support. See you next time.